All right, hello everybody, and welcome to our first lecture on examination and evaluation of the knee. Knee pain is one of the most common symptoms that people will seek PT treatment for, and we can have a pretty large impact on their functional ability. And it starts with a good examination to kind of know the contributing tissues and factors that you're going to be treating to get them better. So here are the learning objectives for this portion of the lecture. After we should have a good understanding of the anatomy and how that will contribute to common problems we will see arise with the knee. We also want to be able to apply the kinematics of the knee joint to the examination process, as well as starting to think about how this may translate into treatment. We should be able to identify factors in our history taking and subjective examination that will be able to streamline our objective exam. And lastly, we will be able to utilize the ICF model in a common framework to have a conversation about common impairments and body structure and function and how this correlates to some of the common participation restrictions and activity limitations that you're going to see with some of these patients. So let's start off with a thorough anatomy review of the knee and point out some unique features that can kind of contribute to some of the pathologies that will arise. So as we go through this, we'll start to discuss those common pathologies that you may encounter as well. So looking at the bony structure of the knee, we can see that it's actually inherently unstable, right? We have this large femoral condyles, these rounded knobs sitting on this flat tibial plateau. You can see out in the absence of support by other stabilizers like the meniscus or ligaments and musculature that it just wouldn't be very stable. So giving away an instability maybe a large complaint of people with knee pain or knee trauma, and it can come from many different issues, including like degenerative changes of the cartilage or the structure itself, or obviously ligamentous damage or meniscal damage. Another really unique part of the bony anatomy of the knee is the patella. Essentially, it's a pulley system to allow for the extension of the knee joint with more torque. So this can be a large source of pathology or pain, including just patellofemoral pain syndrome, which we'll get into later, patellar instability due to the connective tissues that really just keep that patella in the trochlear groove, arthritic changes due to the forces placed on it, tendonitis, apophysitis in appropriate age groups. So it can be a source of a lot of problems and help us a lot with treatment with people with knee pain. Now also just take notice of the femoral condyles and how this creates a path for that patella to move through on that trochlear groove. You can see it's inherently more stable along that lateral portion due to the femoral condyle extending more anteriorly. And then it's also, just look at the surface area of the condyles as well as on the tibia, right? We have a lot of area for articular cartilage. So chondral injuries, meniscal injuries, those kind of things are pretty common in the knee to see, and it's because of just all that surface area that you move through. And they also have a lot of articulating surfaces. You have a couple on the tibia, a couple on the femur, a few articulating surfaces on the patella. All those things cover with that cartilage, so you can see where those type of problems may be fairly more frequent in the knee than maybe other joints. Keeping on with our anatomy review, let's go over some things about the meniscus. The meniscus plays a large role in knee function and definitely warrants more discussion here. So meniscal and chondral injuries, like we talked about just a little bit ago, account for around a quarter of all knee injuries. Females in the older population are more at risk for meniscal tears in general. If we think about side to side, lateral meniscus tears are less common, but we'll see these in the younger athletic populations and associated with more of a singular event of twisting or with or without contact. So if we think about the medial meniscus, this might be more of happening over time with a general wear and tear type thing with maybe not even a specific event to point to. These fibrocartilaginous discs play a huge role in knee stability, like we talked about earlier with those femoral condyles and the tibia not being very congruent. And then it also helps with dispersing of weight bearing throughout the joint, and then it also blocks or limits hyperextension motion. So having those thick centers and inner edges allows it to absorb shock to the knee joint and just disperse it throughout the knee complex. And then this also helps us see some of the etiology of maybe like some OA that may occur years after a meniscus injury or a ligamentous injury. If we put more stress or strain on this meniscus and that wears down where these forces aren't being dispersed properly, next thing you know, we might get compartmental wear and tear that we can see sometimes on x-rays. So like I said, the medial meniscus is more commonly indicated in pathology overall and more prominent in older individuals. That might be due to the fact that it's just less mobile and larger than the lateral meniscus. You can see in this picture that both the ACL and the PCL blend into the horns of the medial meniscus, and that's just part of the connections that it has. Right? It also has connections with other tendinous outliers that blend into it that cause some dynamic mobility for it. But overall, the medial meniscus is just more stable. And so that's why you'll see a lot of times concomitant damage with medial meniscus tears, like in the terrible triad of an MCL tear, an ACL tear, and a medial meniscus tear. So just make sure to remember to review your vascularity of the meniscus with your different zones, because this will affect the kind of the potential for healing and may increase the need for other interventions, especially with when it's combined with other ligamentous injuries of the knee. So the meniscus can tear in a bunch of different ways, including longitudinally. It can flap over. It can be a bucket handle tear. There can be a thing called a parrot tear where it's on the kind of the inner portion of it, a discoid tear where there's kind of a hole in it, so, and other complex tears. So that's going to obviously affect prognosis depending on what type of tear it may have in it. And lastly, just take a second to think about the implications above and below the knee and how stresses may change due to impairment seen in those locations. So let's just take an example of like decreased hip rotational motion and how that may change the stresses placed on the meniscus and the demand placed on the meniscus. Static and dynamic stability of the knee also requires the support of the ligaments, both intracapsular and extracapsular ligaments. So just looking at the knee joint capsule, it's pretty large and fairly lax, right, to allow for that large excursion of the knee in the sagittal plane. So it's mostly made up of like expansions of the tendons of the musculature, coursing distally and then some coursing proximally to the knee. Thinking rationally, the anterior structures are going to be slack in an extended position. That's why we can have the mobility of the patella when we're in a slightly flexed or more neutral position, and the posterior structures will be more slack in a flexed position. Makes sense. The anterior part of the capsule is made up of the medial and lateral retinaculums. These help support and give stability to the patella, with contributions also from the IT band, the vastus lateralis, and the vastus medialis muscle. So if you start to piece that together, you get some information here and possibly see certain impairments that may lead to something we see commonly, a patellofemoral pain syndrome, with maybe some tissue restrictions as well as muscular weakness. So the posterior capsule, it's made up of a bunch of smaller ligaments as well as tendinous expansions of the hamstrings and popliteus musculature. So of importance, as we can see on this picture, the posterior lateral corner and the posterior medial corners, they're both possible sources of injury, usually in combination with more significant ligamentous damage, but it's sometimes regularly missed with a PCL or an ACL tear. Medially and laterally, respectively, we have the medial and lateral collateral ligaments of the knee. That MCL is going to have a stronger attachment to the capsule of the knee, and therefore is more commonly associated with those injuries like above with the terrible triad, where it might be involved with multiple structures, including meniscus tears regularly. Both of these ligaments have solid blood supplies, right? So therefore, they're going to heal independently of other interventions, and in most situations, they're not really going to be touched. Even with an ACL tear, they might just leave a fully torn MCL tear to actually just heal on its own. Intracapsular ligaments include our cruciate ligaments. So just go back and make sure you review what these ligaments are and what their major restraints are, all four of the major ones that we talked about here. Knowing their orientation and the restraint gives you a good idea in regards to what mechanisms might be involved with one of these injuries. So also, as you're reviewing those restraints, take a minute to start to think about what are the common mechanisms that would be involved with these injuries. And we'll go over them later on a different lecture, but start to piece it together. Is this going to be an ACL tear or a PCL tear, just depending on what the subjective mechanism they tell you is. Lastly, let's just go over a little bit of anatomy review on musculature. So major muscles around the knee are comprised of the knee flexors and knee extensors, our hamstring complex and our quadriceps complex. We also get contributions from the knee from our adductor groups, traveling down to the pes anserine, as well as distally from gastrocnemius, crossing the joint line as a knee flexor as well. So really review your muscular origins and insertions, as this can play a big role at the knee. While muscular strains, subjective symptoms, they're not really common at the knee, right? A distal hamstring strain, or where they really feel it at, or a quadriceps strain down low there. But tendinopathies are more common around here, just due to all the tendon insertions. So we can see a lot of problems arise from that. And then histories of change in activity, training levels might point you in a good direction of those. So palpation skills are super important around the knee, and so knowing your origins, insertions, and what muscles and tissues you're going to be actually on is going to be vital to you in diagnosing certain things. So start to think about this as well. The hip musculature playing a role at the knee. If you move your hip just sitting there, kind of rock it in and out, you're going to see where that knee goes into varus and valgus positions, and you can almost feel different stresses placed on it. So a good understanding of the hip musculature and its contributions to just dynamic and static support of the whole lower extremity is going to be really important, and start to be able to apply those concepts to where your knee might be at in certain situations. So if I lack dynamic stability of the hip to control whatever task I'm performing, that added stability is going to have to be gained somewhere else in the system. And we already talked about where the knee is not really a good structural stabilizer, right? It relies on all the things around it. So sometimes that increased irritation, we can start to see problems with the tendons, problems with a lot of the bursa around there, including prepatellar bursas, infrapatellar bursas, or the patellar tendon and quadriceps tendon. So now that our anatomy review is done, let's take a quick review on osteokinematics of the knee. Not a ton of true cardinal plane motions, right, besides the sagittal plane of flexion and extension. But also remember that's a condylar joint, and so there is transverse motion as well as mild amounts of frontal plane motion of varus and valgus. Now think about what transverse plane motion may affect if someone doesn't possess adequate rotational motion at their hips, like we talked about earlier, or think about what excessive valgus or varus stresses may do to certain compartments of the tibiofemoral joint or the patellofemoral joint moving through that trochlear groove. If someone has hip weakness or lacks that dynamic control of maintaining arch height at their foot, for an example. Arthrokinematically, review your tibiofemoral joint and patellofemoral joint arthrokinematics. So you're going to be able to utilize those for treatment in maybe changing range of motion issues that you'll find with the knee. Very commonly, we're going to see a lack of extension range of motion with a lot of diagnoses at the knee, especially arthritic changes, ligamentous damage, those kind of things. So as you're reviewing your arthrokinematics of just the roll and glide, also think about the screw home mechanism and review that of the locking and unlocking of the knee going into that last 15 to 20 degrees of extension, and what kind of muscles play a role with that, and how that joint moves through that last little bit. Also think about like a unicompartmental arthritic change to the knee and how this may affect the ability to lock or unlock out of that in-range position. I placed a graphic at the bottom of this slide showing just the multiple facets of the patella and how they're stressed throughout movement and deflection. So you think about a normal sit-to-stand transfer, that's going to place up to 6 to 7 times the body weight of force through the patellofemoral joint, where running is going to place 3 to 4 times the body weight forces. So obviously with patellar problems, arthritic changes along the posterior part of the patella, chondromalacia patella that's symptomatic, patellofemoral pain problems, where that's going to play a huge role in function because a lot of our functional abilities place a large amount of stress, especially through the patellofemoral joint. So this picture just gives you an idea where the highest amounts of stress are during certain parts of the range of motion. Taking into account the information that we've previously discussed, the clinical examination should really rely heavily on a great subjective and history taking, and I think you guys have that down so far to this point. Unique features of the patient's symptoms, as well as their functional limitations, are going to allow you to streamline your objective examination and end up at the right diagnosis and lead you to the right type of treatment. So Dr. Linville's messenger days, there's glory days of age, sex, and location still apply here, right? With location playing a large role in what you may think is going on or what you will consider for differential diagnosis. So just like always, you got to be careful about that though, because many of the structures of the knee especially are deep, and we can subjectively report these in different areas, such as people with meniscus pain a lot of times will feel it posteriorly, kind of in the popliteal fossa, where they'll feel that pinching sensation or tightness. And a lot of times people with PCL problems will tell you that they have anterior knee pain. So you might be going on a route of just generalized anterior knee pain when really they have ligamentous laxity of their PCL. So just always back that up and prove that you're right with thinking about the location with your other objective examination and testing and questioning. Despite not having as much referred hip pain patterns, we can still see referred pain here, right? Stemming from the lumbar spine, the hip, as well as from systemic issues. RA, systemic lupus, things like Lyme's disease can cause pain there, gout, pseudo-gout, and then other neurological disorders. So questioning on feelings of locking, catching, popping, clicking should automatically direct you towards more cartilaginous, meniscal, maybe even loose bodies in the knee. Things like giving way of the knee, it's a really common report like we talked about earlier, and those are more common with some of our ligamentous damage, possibly meniscal damage, and even later stages of arthritic changes where the joint really isn't stable anymore. With other information on age and mechanisms, then we can start to differentiate those things. Also think about weakness as playing a large role at the knee with some of these symptoms. Quadriceps weakness is a really large factor in people with knee pain and can play a really huge role. So you'll see people all the time with quite significant atrophy of their quadriceps complex, and that's going to help you kind of start to think about what may be playing a role in some of their symptoms. In times where people complain of bilateral knee pain, just be suspicious, just like always, of other possible diagnoses, such as referral from the lumbar spine or some type of maybe femoral nerve or saphenous nerve type entrapments that could happen, or other issues like systemic issues we talked about. If you haven't yet, please take a look at that clinical prediction rule chart made for you. It's a really nice resource with a lot of good information, and a lot of it is just subjective information that you can glean to kind of make some decisions on how to treat people. Just last month, my grandmother calls me, and she was at a friend's house, and she missed a step out onto their deck and went directly down onto her knee. She's telling me about it over the phone and wondering what she should do, and just by listening to her description of it, and having an understanding of clinical prediction rules and the auto and knee rules, I told her to go to the orthopedist and just get an x-ray, right? She's over 55 and she had kind of a direct fall onto the patella, and she was telling me it was hard to bend it. So she actually did have a patellar fracture, but we had to rule that out first, and so then the correct course of action from there was taken. But it was just important for for me to know catch on to those things that she told me and be able to kind of direct her to the right treatment. Some common objective outcome measures that we'll see with knee, again, is the LEFS. Another one that I'll use a lot and is backed up in the research is the patient-specific functional scale. And this is basically where the patient is going to list 3 things that they have a problem with. What are your 3 biggest things? And they list them down, and they basically score them on a 0 to 10 rating scale of how difficult they are or how painful they are, or you utilize their terms to grade it. And then you take those terms and you try and you test them 4 weeks later, 3 weeks later, whatever it is, and you see what the changes in their subjective rating of how difficult tasks that are important to them are. And it's a really good way to write goals, and it's a really good way to see what change of function is, because the knee is really about function, and since it's such that middleman of the lower extremity complex. So going on to that location, I want you to stop for a minute again and kind of make a list of things that you feel could be indicated, diagnoses, tissues, those types of things in each category. So thinking anterior, posterior, medial, and lateral, and then also think about referred pain and where maybe those referred pain symptoms are going to go. And we can talk about these later, maybe during class or during lab time, where we can all get together and make a comprehensive list so you guys have a good example or a good understanding of what may be coming in certain areas. So when we start to think about our clinical examination, again, the subjective has now streamlined us into thinking certain things. We now have our differential diagnoses from there, and now we get into our objective. To this point, we've pretty much just discussed the knee, but I want to just interject here because that knee is really that middleman in the kinetic chain of the lower extremity, and I'll tell people all the time it's the middleman. It doesn't have a whole bunch of control. There can be isolated problems at the knee, but many times we're looking at other sources or originations of the problem that have now led into a knee problem. So a thorough peripheral joint screen of the foot and ankle and the hip and pelvis can play a massive role in your ability to treat these people and kind of understand the underlying causes of things. So clearing those possible contributions above and below is really vital, and maybe even more than any other joint complex. It's also common that in the case of knee pain that we have actual like a primary hip impairment. So things like a slip capital femoral epiphysis in kids like 10 to 17, I believe, overweight. You can see actually anterior knee pain, and really it's coming from a SCFE where this patient's femoral head is kind of sliding off the femoral neck, causing knee pain. With those kids, you're going to see an antalgic gait. They're complaining of hip pain and possibly knee pain, and then a change in their rotational range of motion at the hip that might direct you to getting them some x-rays and seeing if this is going on. Palpation is also a really important skill, kind of like we talked about earlier. There's a lot of different pieces of tissues, right, especially around the front of the knee, the anterior knee, that can be possible diagnoses, and palpation might be the way that you're really able to kind of differentiate, from possibly, let's say, a patellofemoral pain syndrome versus a actual patellar tendonitis versus possibly maybe a fat pad syndrome or those kind of things. So as you break up that anterior knee and posterior knee, think about those. Think about the attachment points of certain musculature and certain bony landmarks that you're going to be able to utilize for palpation. That's going to give you more information to build your diagnosis off of. So discussed earlier a lack of terminal knee extension, talking about range of motion. That's one of the largest findings that you're going to see with many different knee pathologies, especially including like arthritic changes and post-trauma. And then strength-wise, with many times with like a ligamentous injury or a trauma to the knee, you're going to see what we call an extensor lag, which will be seen where quadriceps inhibition is present and the patient cannot maintain a fully extended knee when they ask to perform it like a straight leg raise. You'll see a lag in that extension, and maybe they can get it back, but they're not able to initiate that right off the bat. So when testing strength, that's a good one to kind of look at to see if they have true neurological control of that knee extension and find out an extensor lag. Review your joint mobility. Special testing we're going to go over in class, but there's a lot of different special tests for the knee that are going to allow you to kind of differentiate between meniscal pathology, instabilities, maybe muscular flexibility issues. And then a really important one here is our functional screen. Right? So everything we do basically with the knee is weight bearing, and so things like squatting, lunging, step ups, step downs, those kind of things are going to be really important just to allow you to kind of really see how the knee interacts with all the other body parts, the foot and the hip and the trunk, and really get an idea of some of these motor control and coordination patterns, movement patterns, to really get an idea of how the knee is functioning.